Welcome to our program, Perspectives on Step Therapy in Oncology. I'm Lee Schwartzberg, medical oncologist and medical director at the West Cancer Center in Memphis, Tennessee.
I am Rafael Fonseca. I'm a hematologist at the Mayo Clinic in Arizona and chair of the Department of Medicine.
I'm Jacob Kettle, oncology clinical pharmacist from the University of Missouri in Columbia, Missouri.
And I'm Kristina, oncology navigation director for Sarah-Cannon and East Florida Division.
In this segment, we're going to discuss step therapy mainly through the lens of communication, the communication among the care team, and specifically the communication between providers and the patients as it relates to step therapy. But first, let's discuss what step therapy is. Rafael, can you tell us a little bit about what we're talking about?
Sure. So step therapy generally refers to the framework that has been developed by payers where one has to escalate the level of care. Specifically speaking, it applies to drugs and devices and other medical procedures where you have to try something first before you're able to escalate, usually to the newer, usually to the more expensive therapeutic. And we're here to discuss how this applies to the field of oncology. It's also been referred to as fail first therapy in the sense that patients must show that they either don't respond or cannot tolerate a step lower in their therapy.
And when we're talking about oncology, what are the stakes for patients with step therapy, Jacob?
They can be really extreme. So even whether we're talking about supportive care molecules, antiemetics, growth factor support, bone supporting agents, the consequences of failure in that arena are extreme. ER visits, hospitalizations, extended use of other treatments. But then especially when you move into the case of therapeutic molecules, worse outcomes from disease, sooner death, more risk of relapse, all kinds of potentially majorly catastrophic outcomes.
We're talking about cancer patients who have serious illnesses where the therapy is literally life and death, and
Absolutely.
Picking the right therapy is important.
Absolutely.
Kristina, let's talk about a hypothetical case and how you would approach this. So we have a patient who has a particular disease, and the decision is made by the care team to offer a particular therapy, and then it's all set. The patient is arranged for, let's call it IV infusion, and it goes through the insurer, and all of a sudden it comes back that we can't give that therapy because the step therapy mandates a different approach to that patient. What do you do when you find this out and you have to tell the patient about this?
So as nurse navigators, a lot of the times we get the backlash of all of this that happens. The patients don't necessarily communicate with their physicians, their angst, their disappointment, their fears. So it's really important to educate the patient in a way that doesn't detract from the decision that's been made. A lot of the times our hands are tied and we have, despite having gone through the process. So I think a lot of it is to take away some of that weight and that burden that falls on them and focus more on the psychosocial aspect for the patient itself, and educate them as to why potentially it was denied. Was it a decision made because, when we discuss GCFs, for example, being denied if they haven't had an experience of neutropenia or haven't had a delay in treatment, to kind of give them a rationale as to why the insurance decided, so that they're not necessarily the big bad people, so that they don't obviously lose faith in what is the company that is ultimately helping them get access to that care that they need. So I think a lot of it is how you educate the patient and put a positive spin in the aspect of what could potentially be negative by saying, like I said, GCSF wasn't approved because you haven't failed it, yet. You haven't had the need for it. So they're kind of protecting you in the sense of saying, well, if you don't need it, if it's not broken, don't fix it kind of aspect, is the approach that we normally try to take.
And how successful are you with that kind of approach?
Sometimes it takes a couple times to reinforce that, by educating, also saying, if don't think that you're never going to get that covered also. If we do find that the medication is necessary, it can be brought on board, and now we have the justification and the solid evidence base that you now need it. So it's a Band-Aid, honestly.
Right.
And I think that's one of the issues with step therapy, that it's a Band-Aid, and it's time-consuming Band-Aid, and physicians a lot of the times don't have the time to sit down and reassure the patient as to what it is that has been decided by a third party. So it's a temporary fix, honestly.
Rafael, when you're prescribing a myeloma regimen to a patient, particularly a new patient that hasn't had therapy before, and you've likely gone through your rationale for a particular regimen and something about the particular side effects of that treatment. So how do you approach it when the word comes back that all of your careful plan has to be altered? And what's your approach to the patient then?
Well, first, just a very quick step back, and I would like to clarify for the audience, step therapy is different from prior authorizations in the sense that that's more of sort of an open conversation. I want this drug, I want to get it approved, gets approved, and so forth. Step therapy, from the get-go, consider the steps that are necessary for you to get to the second therapy. So arguably, it's a decision that is made by the payer right from the get-go for the unique patient situation. Now, you asked me how have I dealt with this in myeloma. So fortunately, we haven't had to deal a lot with it, particularly for frontline therapy at this point. Although I have to say, I have to be very careful with the conversation, because if we're using medications for patients who have advanced disease, some of which are being used clinically with great success but are still off-label, we sometimes would go through the conversation with patients saying, we're going to try to get this and we'll work with you, etc. However, we are starting to see step therapy emerge as a qualifier in the area of supportive care. So one example is bone-protecting agents that are being used for multiple myeloma. So should you go through drug A before you get drug B? So as of now, it has not been an issue, but part of why we're having this conversation is to realize that this is a very complex thing, and of course, all of us want to have our patients get the right therapy when they need it. And we recognize there's limited resources and there needs to be some responsible stewardship of how we'll practice medicine. But at the same time, it is critically important that patients get a timely access to their medications, because oftentimes they won't have time to come back and then try this, 2 or 6 months down the line.
I face that in my own practice now with therapeutics, before with supportive agents, but we're starting to see with at least one major insurer mandating generic Doxorubicin as opposed to pegylated Doxorubicin. And as you all know, those have very different side effect profiles. Mm-hmm. They've not necessarily been compared in efficacy in specific solid tumors like breast cancer. And there may be particular patient attributes that would mandate that I would prefer to order one versus the other. And so, for example, if in my breast cancer practice, I have patients who literally will not take a drug if it'll cause alopecia or hair loss. And here, that would be an alternative. And if that's the best drug based on patient preferences, and we like to do a shared decision-making model in taking care of our patients, take into account not only their cancer, which is paramount, but also their lifestyle, their needs, their goals, and what they want to accomplish, particularly when they have advanced cancer, that all of those things play a role. So that can be very disconcerting when we have to go back and say, now we have to use the drug that is unfortunately going to cause hair loss to get the same effect, or we have to pick a different drug. Jacob, what's the communication you have with the patients and also with the other members of the provider team?
Yeah, absolutely.
You have to change.
A lot of times I view my role as pharmacist in managing our infusion center from the perspective of kind of being the ultimate liaison. I have to be able to move very seamlessly between discussing with my prior authorization team, maybe talking on a very high clinical level with our physician team, and transition to speak on a good communication level with nurses, and then even to patients. So I like to think everything starts first with understanding the perspective of the person you're talking to, rather than starting with your response and your reaction, like, let me take a breath and understand where that insurer is coming from. Typically, our approach when we're dealing with a denial, a step therapy issue, is to first think through, okay, utilize my clinical knowledge. Is there something else out there that may be reasonable to utilize, or what would be the consequence of utilizing that other regimen? And then kind of begin a discussion with our physician. Are these other options reasonable? Have we considered them or not? And then we built a process in place about, what do we do if we all as a clinical team believe that this therapy that isn't going to be covered by the insurance company is really what's best for the patient? Do we have a process in place to make sure we support our patient through that? So we kind of built that process in place and have some higher level of physician leadership that are included in that kind of team discussion And then from a patient's perspective, I think you brought all these good points up. Education around the entire issue is really critical, and making sure they understand what's going on, and you also really provide a lot of reassurance. Provide the justification behind where the insurance is coming from. Share your knowledge of evidence-based medicine. What are the gaps between two things? A patient's imagination can run wild when they hear my doctor preferred A and insurance companies requiring B. They can, think they're, sometimes there's a small difference between, what we prefer and whatever is mandated by the insurance. So those are topics that are typically provided to the patient. But again, it all comes back to understanding and starting to facilitate a discussion where you can come up with a solution rather than just kind of an angry reaction of one way is the only way we can choose. And I think we're at a place where we have some parity and options. So
I want to jump in a little bit quickly as to how it affects the patient when they get that news. Or that there's a delay. And I think the focus should be that a lot of the times it puts a negative strain on the physician-patient relationship. And particularly because now they see their physicians as the end-all be-all, and they are no longer allowed or capable of getting what their physician prescribed. And so I think that the stress that it adds to that relationship is detrimental, and that's one of the issues that I have with step therapy, that it undermines that relationship and it undermines the physicians a lot. So when we have to go back to educate them, and even when you do apply and bring in that education as far as the science behind why that decision was made, forget the finances, because unfortunately when you start involving the finances, they don't see that as a justification as to why you're changing it. You can't give a dollar sign to my health.
Right.
So to me, the real emphasis on it is just the effect that it has on that relationship between the patient and the physician.
And if I could complement that just to perhaps even a bit more than the stress, is the whole concept of that fiduciary responsibility that the physician has to the patient. I think we as physicians wear many hats, and sometimes as administrators, in plans, people in policy, etc. But I do feel strongly when you're behind that door with a patient in the room, the only focus should be you doing the best for that person in front of you, because doing short of that betrays that fiduciary responsibility. Now, how do you reconcile that with sometimes having limited resources and inability to prescribe? Well, if you take the example to an extreme situation, first of all, sometimes it's not even feasible. If someone is 90 years old, I'm not going to recommend a stem cell transplant from the get-go. But if you did have a young person in a country where they don't have access to ECMO, you just won't even bring it up, right? But if you do have access to potentially to the drug, I think the decision has to be split twofold. You first make the medical decision and you decide with the patient why you would do that versus the other. And then there's a secondary decision whether it's feasible or not. And that might involve the negotiation, the appeals to some of this process. But at least there's that continued transparency so that a person never seconds guess, am I really getting the best, or is this just something that was somewhat forced on me? Now, I will be the first to say this is very nuanced. This is very, very complex. There are some situations where we have equivalent things, but one of the beauties of oncology is one of our biggest challenges, and that is that things move so fast that we don't have the studies that compare thousands and thousands of patients. We're comparing a relatively small phase 3 trials, sometimes phase 2 trials, but they might represent the best there is out there. So it is something for which there's not a very easy answer.
I want to echo what you say, Rafael, about that our responsibility is first and foremost to the patient, and that we have to make the best decision for the patient. But increasingly, we're also being asked to be stewards at a population level or even a societal level. And I think we all need to share in that. It's not uniquely the responsibility of the provider to limit access or limit costly care on individual bases, because it's going to save the system money. But of course, we need to be cognizant of it,
right,
just like the payer does, just like the intermediaries do, like the PBMs, just like the manufacturers do. So this is a difficult problem that we know about. Step therapy is, in my mind, a sort of a transitional solution and not a very wieldy one. But as we potentially move to a value-based care system, there might be some other ways to improve it. I want to go back to what you said, Kristina, about what the patients are feeling. And one other thing that they don't often talk about, but my nurses come and tell me, is that patients feel guilty when you propose to them they can't get it because they picked the wrong insurance plan. And they say, oh, I had the option to pick A or B, and I took the one with the lower deductible, and now look how it's coming back to hurt me now. So patients have a lot of guilt, and we don't necessarily see it through those eyes, and we really need to be cognizant about that.
So that's
you didn't.
That's something that we really educate a lot, particularly since there are times where they have the options of changing the plans that they're on. And financial toxicity is something that is very real to them. And it's that financial toxicity includes the payments that they can have for their insurances. So it's definitely something that is crucial to educate them as to, you did not make an incorrect choice. You did a choice based on what you could afford or what you had at that time. So going forward, what can we do to kind of ameliorate that situation and make sure that you don't run into the issue where you are again stuck in a place where you can't decide or you can't get the options that you want. But not necessarily is changing to a more expensive plan going to cover more. It's just have to look down to the nitty gritty of it and kind of take that burden away of, you didn't make a wrong decision. You made a decision based on what you had as fact at the time.
Absolutely.
Nobody plans on getting cancer.
So being supportive.
Yeah.
Jacob,
we get to where language is just so important. And kind of rehearsing, what are the right words to, when you're in that heat of the moment, it's very easy to just make a slight miscalculation in choice of words, but the patient may really gravitate to those things. So, spending time working as a group, sharing, what are my motivating factors, what are your motivating factors, and talking, communicating as a team, and then really kind of figuring out what's a good language to use, because it starts with you all. And if we start that patient on a good trajectory, hearing positive language, or maybe they hear, we're going to prefer this, but this other option may be necessary. If you kind of get them set up in that right mindset, it may facilitate a much more smooth transition as they go through the system, particularly if they hit hurdles. Setting them up to understand that maybe part of their story may help for a positive experience.
So is it appropriate to say then that one of the ways that providers can frame the discussion, especially early on in the relationship with a patient, is to not be as prescriptive at the beginning and to say there are several excellent ways to treat your cancer, and this is the one I'm picking, and I have reasons to do it, but there's not, in most cases, there's more than one approach. Sometimes there isn't. And what do we do when there isn't? I mean, what is our approach to step therapy when we don't agree with the choice? What's our recourse and our communication?
So take a case like that where there's no other option, right? That you have a unique set of drugs that you need for a particular treatment. I think there's something to be said about the advocacy that the healthcare team plays on behalf of the patient. I have no doubt that because of the nuances and the complexity sometimes of the authorizations and the appeals, et cetera, there's going to be attrition, both from the healthcare teams and from the patient perspective. So for us to be able to deliver the best care possible, we actually have to serve as advocates for patients. Now, unfortunately, this is not anything that it's codified, that it's reimbursable, that is monetized. So this really comes out of the back of our nursing teams, our medical assistants, our secretaries, and obviously of physicians as well, too, who spend a significant amount of time going through the peer-to-peer review process, providing documentation, and all those things that we know contribute to the already burden and burnout-prone population of physicians.
So we have a process of communicating back to the payer who's made the step therapy decision, and we can be successful with that, assuming that we can have the information and make a compelling argument. So perhaps one other recommendation is to have all that available. We often are dialoguing with physicians who are not in oncology at the payer level, and it can be difficult because they're following a script. But I think in most cases we've been successful if we have a compelling story about why a therapy might be better than another. So clearly we have a big task when we're talking to patients, and step therapy adds additional challenges, but We need to be flexible. We need to be supportive of our patients. We need to explain to them why there may be an alternative, as you said, that would be equally good. And that just means that the universe of care has expanded for our patients. So open discussion, frank discussion, and supportive discussion is the way we can help patients with step therapy.
Absolutely.
Thank you.
Well, thank you all for this discussion. It's been very enlightening. I appreciate it.